Begin now to review vignettes that deal with a broad topic of general surgery. The first group deals with the gastrointestinal tract, and we're going to work our way sort of from the top to the bottom. So the first subheading in turn is of the esophagus. Let me say before I go into the vignettes that pertain to the esophagus. When I talk to my medical students back at home and we deal with esophageal disease, I find that they typically have no difficulty understanding the symptomatology and coming up with good diagnostic guesses. But on the other hand, they are sometimes confused by the bewildering variety of tests and studies that we can do in the esophagus. We can do x-rays in the esophagus, and this can be done with gastrography or barium. We can look down the esophagus, do endoscopy, do biopsies. We can measure the pH in the esophagus. We can measure the contraction, the peristaltic waves. We can do manometry. And so there are a number of things we can do to study the esophagus, and often the difficulty that the student has is which of the tests would be best in a particular situation. So to some extent, I'm focusing the review on that issue, although we talk about the rest of each of the presentations. Let's begin with vignette number 1. A 62-year-old man describes epigastric and substernal pain that he cannot characterize well. At times his description sounds like gastroesophageal reflux, at times it does not. Sonogram of the gallbladder, EKG, and cardiac enzymes have been negative. So here is a gentleman with episodes of pain. Somebody has already thought that it might be due to gallbladder disease, but that was ruled out. Somebody thought perhaps myocardial ischemia, that has been ruled out. And the question comes up, is this due to reflux? If that's the question, is the pain due to reflux? The best way then to answer that would be esophageal pH monitoring. Because even though we could show reflux with x-ray studies, and we could show reflux with endoscopy, we would not be able to actually tie the perception of the pain to the very same time when the pH in the lower esophagus is lower than it should be. And by doing pH monitoring, the patient can click in and mark the times when the pain occurs. This can then be compared in the tracing, and if they coincide with the lowering of the pH, we know both that the patient is refluxing and that is what causes the pain. Incidentally, this would be a vague pain that cannot be well characterized. To digress here for a second, the vignette said every time the patient swallows, he gets this horrible, crushing retrosternal pain. That would be more likely to be what's called a nutcracker esophagus, uncoordinated contractions of the esophagus, for which manometry would be a better diagnostic test. Now let me move on to the next. A 54-year-old obese man gives a history of burning, retrosternal pain, and heartburn that is brought about by bending over, wearing tight clothing, or lying flat in bed at night. He gets symptomatic relief from antacids, but has never been formally treated. The problem has been present for many years and seems to be progressing. Now, there is no question clinically here that we're dealing with gastroesophageal reflux. The presentation is classic. We know this is what it is. But if this has been going on for a number of years, the question we should have in our mind at the present time is, what damage has already been done to the lower esophagus? How bad is the esophagitis? Is there perhaps already a change of the epithelium of the lower esophagus? Does a patient have Barrett's disease? And so here the best test would be endoscopy and biopsies. And I realize that this kind of presentation could simply be treated with antacids and other medical means, but I think the legitimate question here with a long-standing, previously untreated disease is how much damage has the lower esophagus suffered. All right, let's move on along the same line to further development of the same theme here. Vignette number 3. A 54-year-old obese man gives a history of burning retrosternal pain and heartburn that is brought about by bending over, wearing tight clothing, lying flat in bed at night. He gets symptomatic relief from antacids, but has never been formally treated. The problem has been present for many years and seems to be progressing. Endoscopy shows severe peptic esophagitis and Barrett's esophagus. But what I'm going to tell you next, of what ought to be the management in this case, reflects my surgical bias. I am a surgeon and I tend to favor surgical therapy. And I would make the point that many people feel that in the presence of Barrett's esophagus, which is a pre-malignant change, we're justified in doing a Nissen fundoplication. I'm equally aware, though, and I want to alert you to it, that it is possible to get rid of the symptoms with very intensive therapy directed at the acid. And indeed, there is ample proof that if a patient is placed on omeprazole, on the most effective proton pump inhibitors that we have, that we can take care of both the symptomatology and the histological damage to the lower esophagus. But that requires high doses of omeprazole for a long period of time. And I would be reluctant to advise to a patient that all of the acid in the stomach be removed for a long period of time, because acid is very bad in the lower esophagus, but it belongs in the stomach. If you create a significant long-term achlorhydria by this medical treatment, then you're going to have uninhibited gastrin production. Gastrin is a trophic hormone, and you may have changes in the mucosa that are not desirable. And in fact, there are reports of carcinoid tumors developing as a consequence of that therapy. So I would favor in a vignette like this the choice for a Nissen fundoplication. Now let me again pursue that same idea a little further. Let me begin with the same presentation, vignette number 4. 54-year-old obese man gives a history of many years of burning retrosternal pain and heartburn that is brought about by bending over, wearing tight clothing, lying flat in bed at night. He gets brief symptomatic relief from antacids, but in spite of faithful adherence to a strict program of medical therapy, the process seems to be progressing. Endoscopy shows severe peptic esophagitis with no dysplastic changes. Surgical treatment has been recommended. I made the point in the previous vignette that the presence of Barrett's in the minds of many practitioners, particularly surgeons, is a good indication for the Nissen fundoplication. I think a good case can be made also that if a patient has faithfully adhered to a strict program of medical therapy and yet is getting no relief and the process is progressing, that even if there are no dysplastic changes, that Nissen fundoplication should be done. If we accept that idea, and the vignette were to say we are going to do the Nissen fundoplication, what else do we need to know before the operation is done? Essentially then, virtually every study that we can do in the esophagus is going to be done. The surgeon who does this operation will want reassurance that the problem is indeed acid reflux, and pH monitoring will make that obvious. Because after all, the only thing a Nissen fundoplication does is prevent the acid reflux. The surgeon obviously will want to know that enough damage has been done to the lower mucosa to make the surgical treatment advisable, and that was already proven by the endoscopy that showed the severe esophagitis. But if we're going to put a valve which essentially is what an instant fundoplication does in the lower esophagus. We want to make sure that the motility of the esophagus is normal, that the esophagus will be able to propel food past this place that we're going to create into a one-way valve. Manometry, therefore, will be done. The surgeon isn't going to be very happy either about providing a competent gastroesophageal junction if there happens to be pyloric obstruction just beyond, because that forces then the reflux to occur. And therefore gastric emptying studies would also be called for. And finally, if we're going to operate in the lower esophagus, we're going to create a one-way valve with an instant fundoplication, we want to know where the lower esophagus is. And in severe cases, it may have migrated up into the chest, so probably a barium swallow will also be wanted, so we know where is the EG junction and where can we do this. So essentially, if we're going to do an instant fundoplication, we do just about every study that we can do in the esophagus before we do it. I might make an additional observation here. It goes back again to the choice between an instant fundoplication and medical management. At one time, even surgeons were reluctant to do an instant fundoplication because it was a major operation. We had to make a big incision so our big bulky hands could get in there and get to the lower esophagus and to the jaw. But now that we do these laparoscopically, it's really a relatively minor procedure. Patient comes in the morning, gets the operation done, typically goes home the next morning. And so it's not as big of a surgical trauma as it used to be. And therefore that liberalizes a little bit more the indications for the instant fundoplication. All right, let's move on to something different. Vignette number 5. A 47-year-old woman describes difficulty swallowing, which she has had for many years. She says that liquids are more difficult to swallow than solids, and she has learned to sit up straight and wait for the fluids to make it through. Occasionally she regurgitates large amounts of undigested food. This entire description is very good for achalasia of the esophagus. And in fact, as you began to read this vignette, the instant you got to the point that said that liquids are more difficult to swallow than solids, at that point, you already should have had a pretty good inkling that this was going to be a functional problem, a motility problem, not a mechanical problem. A cancer of the esophagus, typically the dysphagia begins for meat and then other solids and then soft food and eventually liquids. And the same is true if you had long-standing gastroesophageal reflux disease with a stricture or peptic ulceration or something. If this were a mechanical problem, the solids would have more difficulty than the liquids. So when the liquids are more difficult than the solids, we either have, well, again, we have a functional problem. It could be denervation up above. If we had been told this patient had just had an operation in the upper neck, it could be that now there is denervation of the sensory branches of the ninth nerve, and the patient is having trouble swallowing liquids. But with this description, this is very good for achalasia. It's classical for patients with achalasia, which incidentally are typically women around this age group. It's classical for them to eventually learn that if they sit up straight, the liquids that have accumulated in the megaesophagus, eventually the weight of the liquid overcomes the resistance of the lower sphincter and they go through. And also pretty typical is the business here of the regurgitation of undigested food. The way this might be given to you on the exam question could be she wakes up in the middle of the night to find food in the pillow, food that she's regurgitated at night that is undigested. All right, how are we going to diagnose that this is indeed achalasia? Well, we could do it with barium studies. He would show the megaesophagus, but he would not tell you exactly the nature of a problem. Well, you could do an endoscopy and you would see the big esophagus again. But probably the best way would be manometry studies. We're talking about a problem of motility. So manometry studies ought to establish the fact that the lower sphincter doesn't relax, that she has propulsion above that, but the lower sphincter doesn't relax. And we can treat these medically with repeated dilatations, or we can treat this surgically with a Heller myotomy, and either of the two would be an acceptable answer. Now let's move on to something that should be very classical, very typical, very easy to recognize. Vignette number 6. A 54-year-old black man with a history of smoking and drinking describes progressive dysphagia that began 3 months ago with difficulty swallowing meat, progressed to other solid foods, then soft foods, and is now evident for liquids as well. He locates a place where the foot sticks at the lower end of the sternum, and he's lost 30 pounds of weight, and this is classical for cancer of the esophagus. The gradual, relentless progression of a dysphagia that began for the solids and then extended to the soft food and then extended to the liquids, and in fact the last stage would be the saliva. Given the background, smoking and drinking, and also being a black patient, this is more likely to be squamous cell carcinoma. There's high incidence in blacks, and there is that etiological agent that is the smoking in combination with the drinking. If we had been told, on the other hand, that this was a patient with a long-standing history of gastroesophageal reflux, then probably it would be an adenocarcinoma developing where the Barrett's esophagus had developed because of the reflux. What do we do next? The way to make the diagnosis of esophageal cancer is endoscopy and biopsy, but don't pick that yet as the answer. Because if the answer is phrased in the typical way, what is the next step in the diagnostic workup, it would actually be barium swallow. Now you see, the barium swallow isn't going to establish the histological nature of the problem. That will be done with the endoscopy and the biopsies. But the morbid fear of the endoscopist who's going to do this study is that he or she may perforate the esophagus in the process of putting down an instrument in an esophagus known by the history to have a tumor that already has very little lumen left. And so that endoscopist will insist on a barium study first, so we can see where is the tumor, how much of a lumen there is left, so that there is a roadmap that precedes the endoscopic procedure. The next thing after that, incidentally, would be a CT scan to determine if it is operable or not. Most of them are not operable for a cure, but frequently still operable for palliation. And then we would typically do a transhiatal esophagectomy, an incision in the neck, an incision in the upper abdomen, a blunt dissection and removal of the esophagus, and then the stomach brought up for anastomosis in the neck. Not the ideal way to reconstruct an esophagus for long-term survival. For long-term survival, it would be better to do a colon interposition. But for the short term that you can expect for a palliative case, it would be the way to go. Let's read the next one. Vignette number 7. A 24-year-old man spends a night cruising bars and drinking heavily. In the wee hours of the morning, he's quite drunk, and he starts vomiting repeatedly. He initially brings up gastric contents only, but eventually he vomits bright red blood. This is a very common thing. Every major hospital in this nation sees a few of these every weekend in the emergency room. This is a classical Mallory-Weiss tear. It is caused by the repeated vomiting, but it's a little tear only affecting the mucosa of the esophageal junction. This is not a perforation of the esophagus. It's only a mucosal tear. It bleeds pretty profusely, bright red blood, and this is the presentation. What we do for the Mallory-Weiss is pretty straightforward. We do endoscopy. The endoscopy allows us to establish a diagnosis. We can see the bleeding point, and we can even do therapeutic maneuvers there because photocoagulation can be used to stop the bleeding. But this kind of a presentation that begins with a repeated vomiting could lead to a different condition rather than the Mallory-Weiss. Let's read vignette number 8. A 24-year-old man spends the night cruising bars and drinking heavily. In the wee hours of the morning, he's quite drunk and starts vomiting repeatedly. Eventually, he has a particularly violent episode of vomiting, and he feels a very severe, wrenching epigastric pain and low sternal pain of sudden onset. On arrival at the ER 1 hour later, he still has the pain, he's diaphoretic, has fever, leukocytosis, and looks quite ill. This is a much less common problem, but a very serious one. This is the Burr-Habs syndrome, the perforation of the lower esophagus due to the repeated and forceful vomiting. And interestingly enough, the two presentations don't mix. If you only tear the mucosa, you get the bleeding. If you do the whole perforation, you get the mediastinitis, without actually bleeding being a main part of a presentation. We should be able to recognize this from the vignette. Repeated vomiting leading to this horrible pain, and now a very sick-looking patient. This is perforation of the lower esophagus, even if clinically we don't see this very commonly. What do we do next? This is important because the prognosis of a patient with a big esophageal perforation depends more than anything else on how rapidly the diagnosis is established and therefore the therapy is done. And so any approach here that would delay the diagnosis would have very bad consequences. So don't pick the answer that says, let's give him antibiotics and watch him overnight. That would be a prescription for disaster. We need to immediately determine what's happening here. Now, if we fear clinically that this is a perforation, we don't want to make the perforation worse. So the answer would not be endoscopy. You put an instrument down there, you could end up looking at the heart and the lungs or the liver or the stomach. We are going to do this radiologically. But again, if we fear that there is a perforation, we don't want to begin with barium. If we put barium into the esophagus, it will probably demonstrate the perforation, but at the cost of compounding the existing mediastinitis, because barium is very irritating when it's outside the GI tract. So that barium that now spills into the mediastinum, potentially into the abdomen, is going to compound the problem. We want, therefore, to begin the study with gastrography. So the correct answer you're looking for is gastrographing swallow. Gastrographing, you probably recall, is that water-soluble medium that we can use as contrast in the GI tract that is far safer than barium if it were to extravasate. I have to add, though, that gastrographing gives really very bad quality pictures. Gastrographing is not terribly, solid to begin with, and it very quickly gets diluted even further with the GI tract fluid. So gastrographing gives low quality but safe pictures, whereas barium gives high quality but in this setting risky pictures. So we begin with a gastrographing swallow. But if you were to be told in the exam question, we've done the gastrographing swallow and it's negative, you don't stop there. Because we know the gastrographing gives pictures of not terribly high quality. We may have missed the perforation that the clinical setting suggests is there, and therefore the gastrographing study was negative. Then we would continue with a barium study. And then immediate surgical repair of the perforation, because if it is delayed, we're going to have a very bad situation in our hands. Actually, this kind of esophageal perforation, the Burr-Habs, is, as I pointed out, very rare. The most common way we see an esophageal perforation is the way the next vignette illustrates, vignette number 9. A 66-year-old man has an upper GI endoscopy done as an outpatient to check on the progress of medical therapy for gastric ulcer. 6 hours after the procedure, he returns complaining of severe, constant retrosternal pain that began shortly after he went home. He looks prostrate, very ill. He's diaphoretic, has a fever of 104 and a respiratory rate of 30. There is a hint of subcutaneous emphysema at the base of the neck. Clinically, there is no question what's happening here. This is instrumental perforation of the esophagus, the one that most commonly is seen. The setting plus that air in the tissues are virtually diagnostic when you put these two things together. So what do we need to do next? Well, obviously, it's not antibiotics, watchful waiting, let's see how he is tomorrow morning, because there is urgency in treating the perforation. We begin with a gastrographic swallow. If it is positive and shows the perforation, we then intervene, do a surgical operation and repair it. And if it is negative, we do then the barium swallow, because we have every clinical reason to suspect there's a perforation, and we want to make sure we recognize it early and repair early. I might add that this vignette clearly shows bad mediastinitis, a very sick patient. I know that there are anecdotal cases, you may be familiar with some, of patients who have an endoscopy and maybe it is followed by a little gastrographic swallow, and lo and behold, there is a teeny bitty extravasation, but the patient looks fine, the patient isn't sick, the patient doesn't have mediastinitis, and the choice may be made in that case to give antibiotics, keep the patient MPO, and just wait, and that patient will probably do fine. But if it is a clear-cut, big perforation, like this one is, with a mediastinitis that is absolutely obvious, we need the immediate repair. If you're given one of these, I might add, and you're told the perforation happened 3 days ago, you finally now make the diagnosis, then it would be actually too late to repair the esophagus. Now the area is going to be so terribly inflamed and that it cannot be done, and that patient would then need esophageal derivation in the neck and derivation at the EG junction, or tying off of the EG junction, and eventually then an esophageal replacement, and that would be a far more complicated situation. All right, let's move down to the stomach. Vignette 10. A 72-year-old man has lost 40 pounds of weight over a 2 or 3 month period. He gives a history of anorexia for several months and of vague epigastric discomfort for the past 3 weeks. I cannot claim that with that history we can tell what the diagnosis is, but we already know this is going to be a malignancy. 72-year-old, a significant weight loss, this is a malignancy. There is, however, enough of a hint, anorexia, vague epigastric discomfort, to think that this malignancy could very well be in the stomach. And therefore, the first thing that you would do in the workup of this patient is to look into the stomach. So the answer you want to look for here is endoscopy and biopsies. And we don't need to precede this one with a barium swallow. The stomach has plenty of lumen. We can do the gastroscopy safely without having to have a roadmap ahead of time. So endoscopy and biopsies. If we find a cancer of the stomach, CT scan will be the next, see how extensive it is, how resectable or unresectable it might be. And then after that, typically surgery. Let's move to the small bowel and appendix. Vignette number 11. A 54-year-old man has had colicky, abdominal pain, and protracted vomiting for several days. He has developed progressive, moderate abdominal distension and has not had a bowel movement or passed any gas for 5 days. He has high-pitched loud bowel sounds that coincide with the colicky pain, and x-rays that show distended loops of a small bowel and air fluid levels. 5 years ago, he had an exploratory laparotomy for a gunshot wound of the abdomen. There are two components to this vignette. The first component, which is the majority of the vignette, is actually a very beautiful description of mechanical intestinal obstruction. The protracted abdominal pain, which is colic in nature, the protracted vomiting, the coincidence between the pain and the hyperactive bowel sounds, the progressive distension, and the x-ray picture. The last line in the vignette gives you the reason. 5 years ago, he had an exploratory laparotomy, so we have every reason to believe the genesis of this mechanical intestinal obstruction is due to adhesions. Now, what we're going to do for management derives from our understanding of what is happening here. You see, this gentleman had a laparotomy 5 years ago. It was 5 years ago, at the time of the laparotomy, that he formed the adhesions. They've been there for 5 years. And yet for 5 years he's been eating 3 meals a day, living a normal life. Nothing bad has happened to him. So what's happening now? Is it that the adhesions got mad? Did the adhesions grow? Did they become malignant? No. They've been there all along the same way. All through these 5 years he's been locking the small bowel as it moves, as it always does, peristaltic activity, has avoided falling into the trap, posed by the adhesions. This particular time he was unlucky. A loop of small bowel got trapped and is now occluded. And therefore we begin the therapy of a patient like this not by rushing to the operating room to untwist or retrieve a piece of bowel, because there is a good chance the same way that bowel got into trouble, it could get itself out of trouble. The same way that for 5 years it was able to coexist with the adhesions could be the case after that bowel gets out. So we typically begin the management, and that's the answer you're looking for in the exam. Nasogastric suction, nothing by mouth, intravenous fluids, and we wait. Wait, let the bowel extricate itself, which in most cases it will do. If it is complete obstruction, nothing is reaching the colon, we typically are willing to wait about 24 hours. If it doesn't get better, we will operate. If it is incomplete obstruction, partial obstruction, something is getting to the colon, you can see gas in the colon in the x-rays, a little gas is passed every now and then we are willing to wait even longer, 3, 4, 5 days. But I have to emphasize that while we're waiting, there is a deadly, horrible complication we have to be on the alert for. That loop of bowel that is trapped, if it gets tightly wedged to where the blood supply is compromised, then the loop of bowel could become necrotic and the patient be in deep trouble. That's a process we call strangulation of a loop of bowel or strangulated obstruction. The earliest manifestation would be fever and leukocytosis, followed soon thereafter by constant pain, eventually signs of peritoneal irritation, tender to palpation, guarding rebound, and if we were foolish enough to wait even longer, there would be reproductive peritonitis and septic shock. So when we have a patient that is being treated conservatively, waiting for the bowel to extricate itself, we are on the alert for this. If that happens, then we immediately go to the operating room. Or if the patient came in already with a fever and the leukocytosis and the constant pain and the tender abdomen, we would also rush to the operating room. Let me read the next vignette, because here is an example of that. Vignette number 12. A 54-year-old man has had colicky abdominal pain and protracted vomiting for several days. He has developed progressive moderate abdominal distension, has not had a bowel movement or passed any gas for 5 days. He has high-pitched, loud bowel sounds that coincide with the colicky pain, x-rays that show distended loops of small bowel and air fluid levels. 5 years ago, he had an exploratory laparotomy for a gunshot wound of the abdomen. 6 hours after being hospitalized and placed on nasogastric suction and IV fluids, he develops fever, leukocytosis, abdominal tenderness, and rebound tenderness. What's happening? It's clear. He has developed strangulated obstruction. And what is the choice you're now looking for in this exam question? Immediate surgical intervention. Okay? So emergency surgery is the answer in this particular setting. Let me incidentally review a thought that you might have had here. If both of these vignettes represent a patient that by virtue of having adhesions in the abdomen gets into trouble with intestinal obstruction, why don't we operate every one of these patients, regardless of whether they have signs of strangulation or not, and get rid of those adhesions so they don't have a problem anymore? Well, we don't do it because when we remove adhesions, they form all over again. And so the objective of surgery for the patient who has intestinal obstruction secondary to adhesions is to rescue the bowel that is in trouble. But unfortunately, we're under no illusions that the adhesions can be eradicated. We will, of course, divide them when we operate. We get rid of all the ones that are there at the time. But we know the patient will form them again. And I'm making this point to point out a different situation in the next vignette. Vignette 13. A 54-year-old man has had colicky abdominal pain and protracted vomiting for several days. He has developed progressive moderate abdominal distension and has not had a bowel movement or passed any gas for 5 days. He has high-pitched, loud bowel sounds that coincide with the colicky pain, and x-rays that show distended loops of small bowel and air fluid levels. So far I have read, again, the classical description of mechanical intestinal obstruction. But now in the last line, we're giving a different genesis for the obstruction. On physical exam, a groin mass is noted. And he explains that he used to be able to push it back at will, but for the past 5 days has been unable to do so. This is now mechanical intestinal obstruction again, but now due to an incarcerated or potentially strangulated hernia. If we were told that he has fever and leukocytosis and this irreducible hernia is discolored and tender, it would be strangulation and we would need emergency surgery. But even if it is not strangulated, we are going to want to operate this patient anyway. And you might use the same argument that we used before for the adhesions and say, now wait a minute, if this patient has had the hernia for many years, has been able to avoid trouble, and now he's in trouble, why don't we give him nasogastric suction, IV fluids, wait, the bowel might eventually get out of there, and then he's fine. Well, the different approach here is justified by what happens after we operate. When we operate for adhesions, the adhesions form all over again. But when we operate for a hernia, we can fix the hernia, and even though every now and then there'll be a patient that has a recurrence, the majority of the patients on whom we repair a hernia no longer have a hernia. So now we have a situation here where we can not only rescue the bowel, but actually get rid of the underlying problem. So every one of these vignettes that might give you intestinal obstruction due to an irreducible hernia, all of them are going to end up in the operating room. The question, though, is when. Let me recapitulate. If you're told, patient comes in, fever, leukocytosis, tender, irreducible hernia, discolored scrotum or inguinal mass, it's surgery right now. It's emergency surgery. We have to rescue that bowel that is dying or resect the bowel that is already dead. If you're told, on the other hand, he's not febrile, no leukocytosis, it's not tender, then we have time. Then we want to repair this hernia, but this is an elective repair. Doesn't need to be done at 2 o'clock in the morning. It can be done tomorrow or the next day. We typically would be reluctant to send the patient home because he might not come back and have the hernia fixed, but it's going to be a more elective thing. And let me add another little detail. You might be given one. Being irreducible for several days, there is some question about fever and leukocytosis. One that sounds like you want to operate as soon as possible, but you are told that the patient is severely dehydrated. You might even be given an electrolyte profile that is clearly abnormal. Then be sure in that case that you don't rush to the operating room, but that you first rehydrate the patient, correct the fluid and electrolyte problem, and then promptly thereafter operate on the patient. Let's move to vignette number 14. A 55-year-old woman is being evaluated for protracted diarrhea. On further questioning, she gives a bizarre history of episodes of flushing of the face with expiratory wheezing. A prominent jugular venous pulse is noted on her neck. It's not a very common problem, but it's so characteristic you should be able to recognize what it is. This is the carcinoid syndrome. This patient has a carcinoid tumor, most commonly, most likely, in her small bowel. It's probably in her ileum someplace. If she had simply the tumor there, she would not have these kind of systemic manifestations, because as that tumor makes serotonin, the serotonin is deactivated in the liver. But if she also has liver metastasis, now the serotonin made by the carcinoid metastases that are in the liver is dumped directly into the inferior vena cava, and they get into the systemic circulation. That circulating serotonin then gives her the flushing of the face and the expiratory wheezing, and it also damages the valves in the heart. Now, the lung happens to be a second site at which you can deactivate serotonin. So the left-sided heart valves are protected because they have that barrier, that lung that deactivates the serotonin. The right-sided valves are the first ones that get it. And so this lady has developed tricuspid damage, as evidenced by the prominent jugular venous pulse in her neck. This is carcinoid syndrome. How do we diagnose this? We start with serum determinations of 5-hydroxyindolacetic acid, which is a byproduct of the serotonin breakdown. And then later on, we'll try to find the primary tumor and remove it, and do what we can for the liver metastases. If there are only a few of them, we may remove them as well. Carcinoid happens to be a pretty slow-growing tumor, so any effort at palliation would be worthwhile. And I'm going to conclude this part of the review with a vignette that is very, very likely to be on the exam. I can think of very few surgical conditions that are more common, perhaps more important, than acute appendicitis. Let's read vignette number 15. A 22-year-old man develops anorexia, followed by vague periumbilical pain that several hours later becomes sharp, severe, constant, and well localized to the right lower quadrant of the abdomen. He has abdominal tenderness, guarding, and rebound to the right and below the umbilicus, temperature of 99.6, white count of 12,500, with neutrophilia in immature forms. This happens to be a pretty classic case for acute appendicitis. And even in the 21st century or whatever, even in this highly technological times in which we live, when a patient has a classical clinical presentation for acute appendicitis, the only correct answer will be emergency appendectomy. This patient doesn't need fancy diagnostic studies that would delay the surgical intervention. It's very important in acute appendicitis, I might remind you, to operate before there is perforation. The appendectomy we do in an acutely inflamed but not perforated appendix. That patient goes home the same day. The appendectomy we do in a perforated appendix ends up in the intensive care unit, all kinds of complications, prolonged postoperative course. The difference in morbidity and mortality is gigantic. We want early intervention. But I have to then guide you to assess, why did I say this is a classical case, the one that calls for the immediate appendectomy? Let's begin from the beginning here. He began with anorexia. That's classical. If you have an exam question that says the patient has right lower quadrant pain, etc., and it says, and the patient is asking when can he have a big steak and French fries, that's unlikely to be appendicitis. It could be, but it's unlikely. If you begin with anorexia, that's good for acute appendicitis. Next thing that makes it classical, the vague periumbilical pain for a few hours before it becomes sharply localized to the right lower quadrant. Another classical thing. Again, if we have a vignette that begins with right lower quadrant pain, it could be appendicitis, but it would not be a classical presentation. It is also classical, the fact that the physical findings are all confined to the right lower quadrant. That when the abdomen is palpated, the pain and the guarding and the rebound are not all over the abdomen, but only to the right or below the umbilicus. Again, if we have the exam question that sounds like appendicitis, but it hurts everywhere when we examine the abdomen, that's not classical. And in fact, even the level of fever and leukocytosis given here is pretty classical. So this vignette, the answer is emergency appendectomy. Now, what about if it had been one of the not typical ones? There are two tests that could be done for the non-typical, maybe acute appendicitis, maybe not acute appendicitis. We can do either an abdominal ultrasound, that is to say a sonogram, or a CT scan. Each of them, either of these are very reliable if properly done. Now, the sonogram is cheaper than the CT scan. You might say, therefore, a better choice. But sonogram is very much operator dependent. The sonogram, to be properly interpreted and read, you need an expert to do the test, an expert to read the test. I don't know if you have ever attempted to read sonograms on your own, but if you're not a radiologist, that thing looks to you like your TV on the blink. It looks like those cable channels you don't pay for and you're not supposed to see. And so if you don't have expert sonographers available 24 hours a day to read a sonogram, then your hospital isn't really equipped to use the sonogram for this diagnostic dilemma. In that case, we use the CT scan. Because even though the CT scan is a little more expensive than the sonogram, it can pretty much be read by anybody. The CT scan is a more easily identifiable picture. So the correct answer, I'll repeat then, for the vignette that sounds like acute appendicitis but is not typical for acute appendicitis, it's either sonogram or CT scan. And be reassured, as I pointed out before, you are not likely to be given both. Both are potential correct answers. In the very unlikely event that both were to be given, a pretty good general rule to follow in the exam is if two tests are known to give you the same kind of answer, pick the cheapest of the two, which would be the sonogram. But again, I don't think you'll have both given on the same vignette.